Good morning for those of you that are joining us from Hong Kong, and good evening for those here in the United States. I am pleased to welcome you to the latest in our series of closing seminars for the National Academy of Medicine, University of Hong Kong Fellowship in Global Health Leadership. Our 2023-2025 fellow, Dr. Nason Tan of HKU, will be providing an overview of his experience during this fellowship with a particular focus on the topic of that which he engaged most deeply with NAM projects, community engagement and its relevance to health, the environment, and resilience in the face of change. Dr. Tan will be joined by a panel of experts who will offer their comments following his presentation, and we will have time at the end of this webinar for questions from the listeners, which you are welcome to submit using the Q&A function at the bottom of your screen. To kick off our program today and to provide context for Dr. Tan's presentation, we will have opening remarks from officials from both the National Academy of Medicine and the University of Hong Kong. I would therefore like to turn over the microphone to our first speaker, Dr. Victor Zhao, President of the National Academy of Medicine, and one of the creators of this joint fellowship program and a strong supporter of our engagement with HKU. Dr. Zhao?
Thank you, Greg, and hello, everyone, and particularly hello to Professor David Bishai and also to our fellow, Nason Tang. So I'm honored to open the third NAM-HKU International Fellowship in Global Health Leadership Seminar. This is co-hosted, as you know, by NAM and HKU, and we feel very privileged to be collaborating with HKU on this pioneering effort. As we open the seminar, I'd like to extend my special thanks and gratitude to Professor C.S. Lau, the Dean of the Li Kai-shing Faculty of Medicine. He's not able to attend today, but we do want to thank him. I know his travel precludes him from joining us today. I did have a chance to meet with him in Berlin at the World Health Summit, in which we discussed this joint program, and I think that we're both looking forward to continuing and deepening our partnership together, NAM and HKU, and then the university is working to expand the vision, a broader set of fellowship activities. Also, Professor Chia-Ching Ling, the Director of School of Nursing at HKU, who is here, and we want to thank her for support of the joint program and for her dedication for international academic collaboration more broadly. To Keiji Fukuda, the Honorary Professor and former Director of School of Public Health of Hong Kong U. He played an important role in the creation of this program, and we're certainly grateful for his report. And finally, last but certainly not least, my friend, Professor Sophia Chang, Senior Advisor to the President's Office at HKU, Professor Director of HKU Primary Healthcare Academy, and I believe she's attending. And hello, Sophia. Sophia, as you know, served as Secretary for Food and Health for Hong Kong government from 2017 to 2022. And during that period, Sophia and I had really had many ideas of creating such a fellowship. It's great to see it coming to fruition. And of course, for those who are not familiar with us, let me say a word about National Academy of Medicine. What we do, who we are. Some of you may know the National Academy of Sciences, our founding academy. It was founded by Abraham Lincoln and Congress in 1863 as a nonprofit independent institution to advise the U.S. government in the well-being of the population. And then in 1970, because health would become so important, the NAS founded the Institute of Medicine, which then become today National Academy of Medicine. So you can imagine that over the years, our mandate has expanded because we see the need to work with experts not only in U.S. but across the globe, partner with organizations like yours worldwide to really address challenge and improve health for all, we say, not just domestically but globally, and not just for privileged but also everybody, especially underserved. Now, the International Fellowship is a natural extension of NAM's work in this space because we recognize we need to build a pipeline of health policy scholars trained in bridging science with policy, which is so important, certainly as I learned this over the years. The whole idea is to put forth informed solutions to some of the world's most critical health challenges. And this partnership between HKU and NAM certainly aspired to do this and was first established in 2018. So we did have some very generous benefactors, such as Dr. Patrick Poon for the first three cohorts, and later Swan Jing Sung Foundation for a recent two, as well as support from HKU. Of course, this program has supported fellows, five fellows between 2019 and 2025. So through this fellow program, we help train the next generation of global health leaders to develop evidence-based medicine policy that will foster better health in their home countries. As you hear later on from Nason, he certainly has done a great job demonstrating the usefulness of this program in thinking about the top issue of resilience and, of course, showing the next generation of global health leaders are in good hands. These fellowships will also create a network of experts. Their fellows, along with people that they meet at national academies and globally, which will strengthen international efforts to improve health outcomes everywhere. So, needless to say, we're really pleased to have Dr. Nason Tang as our fourth fellow, and he's been a wonderful asset and valued colleague to the NAM. During his fellowship, he worked with a team on grand challenge and climate change and health, with a focus on Climate Communities Network. You know, this network, he may talk about this, brings together community leaders. So coming out from our ivory tower, we realize that you can't change health unless you can reach everyone. You can't change health unless community trust you and believe you and work with you to co-develop solutions and to co-produce them. So this is why the whole idea of this network to bring together organizations in community which are disproportionately impacted by climate change and health-related outcomes. So what this does is brings expertise from community, their experience and efforts to address the structural drivers and even distribution of climate health-related outcomes, and of course in member communities. So having Nason's perspective from outside the States was really valuable. And through the network, he also had a chance to engage with his mentor, Lloyd Michener, my good friend from Duke, and where he and I worked together quite a few years, Lloyd being the chief of family medicine and myself as the chancellor at the time. So Lloyd, so good to see you for joining us today. And I really look forward to hearing you. So with all that, let me turn over to Professor David Bishai, who's the Director and Clinical Professor School of Public Health at HKU, to say a few words. Thank you very much indeed. I may not be able to stay through the whole thing, but I'll stay as long as I can. Thank you.
Thank you, Victor. I'm so glad that you mentioned all of the dignitaries that are here and all of the support that we've had throughout the years of this program. I'm very grateful to acknowledge Professor Keiji Fukuda, my predecessor as director of the School of Public Health. His support for this program has been so essential in its success. I also want to thank Juliana Jung, who's one of our current fellows, who's also here in the audience. Thank you for coming, Juliana. And I also see that Professor Kim Chow is here from Chinese University of Hong Kong. But let me move on to, again, recognize that this program would not be possible without the support of our donors. And the Sun Chi Sun Charitable Foundation has been very supportive, as had the Patrick Poon. We're so thankful for their support. Our vision was articulated by Victor. We see the need for leadership in our region, the leadership that combines the best talents from the National Academy of Medicine with our talents here in Hong Kong. Our School of Public Health has an overall strategic vision of building better health and better health leadership in Asia through these partnerships. And so we're so thankful that we could participate this way. A little bit about Nason. I've been so pleased to be able to work with him in this project. He focuses on community and how the community is part of our solution finding. And I was with him last November as we hosted a workshop on the skills in community building through the Support, Appreciate, Learn, Listen, and Transfer program, where we hosted Marlo Rue from the Constellation. And we practiced these skills and we brought them into our curriculum. And with people like Nason, we're able to create a multiplier effect where our students continue this. He'll tell you more as he begins to give his presentation, but future developments of this approach to the practice toolkit that makes our profession a profession, the humanization of whole populations requires the engagement that you'll hear about in Nason's talk today. And as teachers, as well as researchers, this is exactly what we're looking for. So I want to close by thanking Dr. Victor Zhao and Greg Margolis and Yumi Phillips and Kelly Robbins for all of their help in putting this together and helping facilitate what we're about to hear. I'll pass over the microphone now to Dr. Greg Margolis. Go ahead, Greg.
Well, thank you very much, Dr. Bishai and Dr. Zhao, for setting the stage for our main presentation today. As you've heard, our fellow, Dr. Nason Tan, is going to be presenting on his work. He was born in Malaysia and educated in India and Hong Kong. Dr. Tan currently serves as a senior lecturer at the School of Public Health in the University of Hong Kong, with a diverse background that includes roles as a humanitarian field worker, board president, and Regional Operations Support Unit Director at Doctors Without Borders Hong Kong. Dr. Tan has accumulated 20 years of clinical expertise in addressing tropical diseases and epidemics across various countries such as Sierra Leone, Ethiopia, India, Nepal, Cambodia, Malaysia, and Borneo. His dedication to healthcare activism is exemplified by his involvement in critical initiatives during the COVID-19 outbreak in Hong Kong, focusing on assessment, mental health interventions, and elderly care homes, vaccination programs, and training efforts. Dr. Tan's primary focus lies in advocating for vulnerable communities, addressing key issues including health equity, planetary health, mental health, HIV, hepatitis C, substance misuse, and their integration into the wider public health landscape of the region. He is passionate in grassroots initiatives such as community engagement, community-based participatory research, and implementation science and advocacy. Nason, we look forward to hearing about your expertise and experiences during your 3 years as an NAM-HKU Fellow and the insights you've gained on community engagement. Dr. Tan.
Thank you, Greg. Thank you for the introduction. Let me just share my slide now. So good morning and good evening to our guests who tune in today. To frame our conversation, I'd like to share my positionality. My perspective is shaped by my role at the University of Hong Kong as an educator, where I oversee global health, medicine, and public health courses, and also as a public health practitioner. I also had a privilege to be in Washington, D.C. and join the NAM's Climate Communities Network. I would like to give a shout out to my colleagues in the NAM. Thank you so much for hosting me. Now, my commitment to community engagement was forged not in academia, but through early experiences working with Doctors Without Borders and several NGOs in Southeast Asia, where I witnessed the profound gap between institutional intent and community reality. I'm here today as an insider within the systems we need to change. And I believe our highest calling is to cede power to those we aim to serve. I'm here to learn with you and to explore how we, as leaders, can operationalize that humility. My hope is that my presentation sparks not just discussion, but critical self-reflection on our own roles and power within these systems. For the next 30 minutes, I will demonstrate that our siloed models are not just inefficient, they are a direct liability in facing interconnected crises like an aging population, climate change, and systemic inequity. The solution is community engagement. I will prove this with two case studies that redefine health and the environment, where success hinged on three critical shifts: transferring power, recognizing local knowledge, and co-creating solutions. Finally, I will provide the practical blueprint for how to achieve the closing three critical gaps between knowing and doing. This is the path forward. Let's start with the context. For decades, we have managed health, environment, and resilience as separate domains. Each has its own major issues, funding streams, agencies, expertise, and success metrics. This model has achieved significant yet isolated advances. Unfortunately, this siloed model would not be effective in addressing the increasingly complex public health issues we face today. Let's ground this in data. Globally, the population aged 60 plus will double to 2.1 billion by 2050, with the most rapid growth occurring in low and middle income countries, according to WHO. Here in Hong Kong, the situation is even more acute. Our elderly population is projected to swell to over a third of our total population. This isn't just a demographic shift, it's a systemic shockwave. With aging comes a predictable rise in chronic diseases and complex health and social care needs. Our current systems, which are built for episodic, acute care, and fragmented social support, are structurally unprepared for this tidal wave of long-term interconnected need. Just as we face this unprecedented demographic shift, we are simultaneously colliding with another interconnected crisis: climate change. We are now in a world where global temperatures consistently exceed 1.5 degrees Celsius. This isn't a future trend. It's a present-day health emergency, responsible for over 540,000 heat-related deaths annually and putting 1 in 12 global hospitals at risk of failure. And these two crises are not parallel lines. They are on a collision course. The very same older adults that we just discussed, those with chronic diseases, disabilities, and even older women, they are disproportionately vulnerable to extreme heat, climate-related diseases, and the mental trauma of disasters. Our siloed systems force us to treat aging and climate as separate files, but in reality, they are a single compounding threat to human security. We must redefine resilience beyond simple response and recovery. It is the strength of a community's autonomous adaptive capacity. Yet, the increasing frequency of climate-driven disasters is shattering this capacity, eliminating the crucial recovery period. The consequence of inaction is a system that actively compounds risk. Without addressing root causes, each new crisis deepens societal fractures, amplifies pre-existing inequities, and fuels a destructive cycle of mistrust. Therefore, today's biggest challenges, as we have seen, from pandemics to climate-driven disasters, do not respect these institutional boundaries. This creates dangerous blind spots and perpetuates the inverse care law, where systemic support is weakest, where needs are greatest. As a result, our 20th century structures, are failing 21st century synergistic threats. This reality forces us to confront the central challenge. How do we integrate our siloed systems to effectively address all these interconnected problems? Let's look at the answer. The only entity that experiences health, environment, and resilience simultaneously is the community. Therefore, community engagement is the non-negotiable strategic linchpin that can weave our disparate systems into a coherent, equitable, and effective whole. I would like to share a few updates on community engagement in public health before I show you those case studies on how community engagement is the answer. This paper by Yuan et al. In 2021 was a study on evolution, significance, and future directions of community engagement in public health from 1980 to 2020. A notable rise of publications was seen from year 2004, accounting for 91% of total publications. Topics such as community-based participatory research and community resilience have gained traction, particularly following significant health crises like Ebola and COVID-19. The analysis reveals a growing interest in community engagement in public health, with 117 countries contributing to the field, primarily from North America and Europe. Other major developing countries include South Africa, India, Brazil, and China. The most cited article, published in 2010, focuses on community-based participatory research and has been cited well over 650 times. The literature emphasizes the importance of community engagement for personal survival, health equity, and ethical considerations in public health. The following recommendations are based on the results observed in the analysis. Establish coordinated policy frameworks to integrate community engagement into public health strategies. Address the mismatch between healthcare demand and supply to ensure equitable access to services. Implement innovative measures to promote community ownership, empowerment, and sustainability in health initiatives. Develop new assessment methods that focus on both outcomes and the processes of community engagement. Now, CDC has published 3 editions of the Principles of Community Engagement. The first edition, published in 1997, was a foundational guide for engaging communities in specific research projects or health initiatives. It had 9 principles, with the core philosophy of involving communities in public health. Its primary audience then was academic researchers and government agencies. The second edition, as shown here, which was published in 2011, recognized engagement as a two-way street and acknowledged the growing evidence base for community engagement. Its core philosophy was partnering with communities to improve health. Primary audience was broadened to include public health practitioners and community-based organizations. Community engagement can also be seen as a continuum of community involvement. Depending on the level, the magnitude of involvement, communication strategy, impact, and shared decision-making varies. A local health department can move from one level to another to reach its goal of protecting and improving community health. It also depends on the community's capabilities and desire, if they prefer to be involved, to what degree and level. In the latest 3rd edition, which was published this year, the core philosophy is transforming public health for health equity, evidently as a reaction to post-COVID-19. Several key shifts were noted, such as it centers health equity and social justice as the ultimate goal. demands authentic partnership and shared decision-making, focuses on sustainability and long-term commitment, adds the new principle of trustworthiness as a fundamental element in sustaining community engagement and advancing health equity. The third edition is not just an update. It is a call for fundamental redesign of public health practice. It challenges institutions to move from managing community input to being accountable to community-led power. The ultimate goal is to build public health systems that are worthy of the resilient communities they serve. In the third edition, a conceptual model to assess meaningful community engagement was put forward. This was the effort of the organizing committee from the National Academy of Medicine in 2022, and Professor Lloyd Michener was one of the organizing committee. He probably could fill in more on this later. Now, this model centers community engagement and core engagement principles, and it identifies outcomes that are associated with meaningful community engagement, such as strengthened partnerships and alliances, expanded knowledge, improved health and healthcare programs and policies, and thriving communities, which can form the basis for assessment or measurement efforts across various stages, models, processes, and partnerships of engagement. After the key updates, I will now illustrate how community engagement redefines health, environment, and resilience. The first case study is a community asthma prevention program based in Philadelphia. For those of us who have managed asthmatic patients in the emergency department, pediatric, or adult medicine wards, it's frustrating to keep seeing patients coming back. As clinicians, we stabilize their condition, prescribe medicine and inhalers, and then discharge them back into the same environment that caused their attacks in the first place. It's even more frustrating for the patients, for they know they will be back soon. From global policy to local data, the evidence is clear. Unhealthy housing makes people sick, and effective health interventions must start at home. Based on this evidence, the CDC Task Force officially recommends home-based, multi-trigger interventions as an effective strategy to improve life for asthmatic children and adolescents. The Community Asthma Prevention Program, or CAPP for short, was established in 1997 at the Children's Hospital of Philadelphia to reduce asthma disparities by offering clinic, home, and community-based education services to children with asthma. Out of this program, they realized that just addressing non-structural housing issues was inadequate. So they developed the CAP Plus program to address structural housing issues. To do this, the hospital partnered with local non-profit home repair agencies and leveraged the community benefits funding from the hospital along with philanthropy to fund the endeavor. CAP utilizes a community-based approach via their community health workers who would actually do home visits to implement asthma education and asthma trigger remediation interventions in homes, such as trigger mitigating supplies, which include mattress or pillow covers, asthma-friendly cleaning materials, roach bait and mouse traps, and a new spacer mask. If someone has structural issues to be addressed, substantial structural home repairs were completed to further reduce asthma triggers caused by mold or mildew, pests, and dust. This is an image of structural repairs done in homes. The repairs focus on dust, mold, and pests. The whole program ended up fixing 97 homes between 2018 to 2021, and their evaluation showed qualitative improvements in asthma, housing stability, and livability in the house. This pilot study demonstrated the feasibility of healthcare organizations partnering with home repair agencies. With a signal for improved asthma control, it allowed the health system to address social determinants of health that are outside of healthcare providers' routine scope of services. As you can see, all the parameters related to asthma control, such as nighttime systems, rescue medication use, absenteeism, and also emergency visits, have all improved. This program has won numerous awards for community champion in asthma management. There were lessons learned for sure. First, setting expectations for homeowners at the beginning of the repair process. When possible, allowing homeowners to prioritize which repairs are made, and the importance of having community health workers whom already have the trust of the community serving as a liaison between the homeowner and the contractor. Definitely, we also need commitment from our stakeholders, building relationship, and where everyone could collaborate, having this shared vision of all the goals mentioned. The second case is on redefining the environment from the regulation of illegal logging to co-stewardship. In this case study, we will visit Health in Harmony, an NGO which supports 135,000 community members to protect over 3 million hectares of tropical rainforests in Madagascar, Brazil, and Indonesia. Health in Harmony has invested in many innovative paths to forest protection and stewardship. At its heart, it is innovative radical listening approach, which has been effectively used with rainforest communities worldwide. This study was a 10-year analysis by Stanford University and published by the Proceedings National Academies of Science. It shows that Health in Harmony's $5.2 million investment in community design solutions in Indonesian Borneo has averted $65 million in carbon emissions alone, reduced logging, increased health and well-being, regenerated rainforests, and demonstrated that solutions exist to improve the health of people and the planet simultaneously. The project is located at one of the national parks in Borneo, where indigenous communities and locals reside nearby. The high rate of illegal logging was a concern. Now, naturally, the thought would be, if we enforce some regulations, that would be the end of it. But the failure to understand and address the needs of local people can lead to unsustainable forest use. When communities who are already suffering from poverty, they have few alternatives to illegally extract resources and convert land to survive. To find out about attitudes towards forest conservation and drivers of illegal logging, a 400 hours of focus groups spanning over 2 years were held with over 500 community representatives. They identified a major basic need and driver of illegal logging being lack of access to healthcare. The radical listening approach is based on the principles of interbeing, anti-colonial, reciprocity, and community intelligence. The usual process follows a pre-assessment phase, an initial radical listening meeting, a series of follow-up project honing meetings, the signing of a contract, implementation of the agreed upon project, and follow-up once the project is complete. Radical listening is a form of active listening. It's about listening to a group. It's a process of letting go of the outcomes and trusting the community to find their own solutions. The interventions included providing clinic services that accept non-cash payments, educating on forest conservation, and offering opportunities for alternative livelihood training. It's not enough to tell people to stop logging illegally, but you need to provide alternatives so that people can still have their livelihood maintained. Communities were also further incentivized when they reduce their logging activities. The project has shown us that it is possible when we engage communities meaningfully, we can transform environmental regulation into co-stewardship. Environmental protection is not just regulatory compliance, but the community's right to co-steward their own land, air, and water for collective well-being. As we have seen from the two case studies, a critical shift is required to move from the traditional extractive model to a transformative co-creative model of community engagement. It involves treating the community as a sovereign partner in diagnosis, decision-making, and action if we wish to address root causes or system issues. Next is the how to enable the critical shift. As we have seen, the stakes have never been higher in the current context of interconnected crisis. Siloed thinking will fail us. Community engagement, done right and meaningfully, leads to a resilient community that can regenerate in addition to responding. Resilience should not be an excuse to let our system flaws persist. Rather, I would argue, community engagement is the key to fixing the systems. There are three gaps for bridging the knowing to doing. The power gap. This is the chasm between calling for partnership and actually sharing decision-making and resources. The incentive gap. This is the misalignment between our stated goals and how we measure success, publish, and fund. The infrastructure gap. This is the lack of permanent funded structures to sustain engagement beyond the grant cycle, the curriculum and training of students and practitioners. First section, fixing the power gap. The current model typically invites community members to join our predefined meetings with our agendas and our jargon. The shift required will be co-creating the governance structure from the start. So what can we do? Number one, ensure community representatives have real sway over what research gets funded. Second, develop funding opportunities with communities, not just for them. Third, trust communities to allocate resources as they know best. This is the ultimate test of shared power. Second action, fixing the incentive gap. The problem is we fund a 3-year project to engage the community, but our academic and institutional incentives reward the academic paper that comes out of it, not the engagement process or equality, the community's increased capacity, or the solved problem. This creates a fundamental misalignment. So what can we do? For researchers and institutions, you can champion new criteria that value co-authored publications with community partners, policy changes, and documented community impact as highly as first-authored papers in high-impact journals. NAM can lead by creating a toolkit for universities to adopt this. For funders, first, require and fund post-grant sustainability plans co-developed with communities. Second, fund the infrastructure for community engagement, such as staff, training, not just the programmatic activities. Third action on fixing the infrastructure gap. The current flawed model is that we treat community engagement as a time-limited project. When the grant ends, the relationships and capacity often dissolve. The required model is where community engagement is treated as a permanent platform, a core function of public health, just like our epidemiology or lab science. This requires dedicated, trained, permanent staff and budgets. The proposal will be that every major academic health center and public health department should have a community engagement core or office, not an add-on, but a central unit that, number one, provides training in cultural humility and power dynamics for researchers. Second, maintains a long-term trusted relationships with community partners. Third, manages a transparent process for matching community priorities with research interests. And lastly, holds the institution accountable to its engagement promises. To recap, this transformational shift requires us to cede control, to change what we value, and to make a long-term investment. It takes a bit of courage. Note on teaching community engagement. It's been found that the integration of various critical pedagogy principles cultivates critical consciousness, professional humility, and the ability to partner authentically with communities to address public health challenges. Cultural humility is the key to sustaining community engagement. Without a doubt, community engagement is the heart of the entire Sustainable Development Goals framework. In fact, for academic medical institutions, community engagement should be the fourth mission after education, training, and research. A common core course in the first year for all undergrads, exploring social determinants of health, climate change, health inequities, social prescribing, via community engagement would be ideal. Open science projects, they are excellent learning platforms where students and community members collaboratively analyze real-world health challenges. In terms of curriculum, this could look something which incorporate problem-posing sessions, fieldwork, cultural humility, co-driven projects with community members, stakeholders mapping, and engagement strategy. Coming to the conclusion and next steps. So for Hong Kong and NAM, the call to action would be launch a national commission on integrated community-powered health, develop a blueprint for action with standardized power-sharing metrics, publicly recognize institutions that successfully operationalize this model. And I conclude that we can no longer afford to see community engagement as a peripheral activity. It is the core strategic discipline for the 21st century. It is the only force powerful enough to break down our silos, redistribute power, and build a world that's not just healthier and more resilient, but fundamentally more just. I shall end this presentation with a quote from Lao Tzu. Thank you. I'll pass back the mic to Greg.
Thank you so much, Nason, for your very insightful presentation, which I think will provide great basis for discussion on this important topic. Next up in our program, we'll have a panel of three distinguished experts here today to offer their comments and lead our questions and answer session. First, I'd like to introduce the panel moderator, Dr. Andrew Park, a lecturer in the Division of Health, Economics, Policy, and Management at the HKU School of Public Health. In addition to his teaching duties, Dr. Park is also the placement coordinator for the field placement capstone of the Bachelor's of Arts and Sciences in Global Health and Development program at HKU. Dr. Park's research and teaching interests include the history of international relations, multilateral organizations, and contemporary global governance. Prior to joining the School of Public Health, he taught courses in HKU's Department of Politics and Public Administration on humanitarian intervention, the politics of international law, and global governance. Before moving to Hong Kong, he worked in Beijing with the German International Cooperation Agency on projects relating to climate change, mitigation, and adaptation. Joining Dr. Park on the panel is Dr. J. Lloyd Michener, Emeritus Professor of Family Medicine and Community Health at the Duke University School of Medicine and Adjunct Professor at the University of North Carolina Gillings School of Global Public Health. He also serves as the chair of the board for the Foundation for Health Leadership and Innovation and is a member of the National Academy of Medicine's working group on assessing meaningful community engagement. In addition, he serves as chair of the Department of Community and Family Medicine at Duke for more than 2 decades and was the founding director of the Duke Center for Community Research. Nationally, he has served as the founding co-chair for the Community Engagement Steering Committee for the Clinical and Translational Science Awards of NIH and as president of the Association for the Prevention, Teaching, and Research. He has been a member of the National Academy's Committee on Integrating Primary Care and Public Health, the board of directors of the Association for Academic Medical Colleges, the NIH Council for Contemporary and Alternative Medicine, and many, many other communities and boards. I would especially like to acknowledge Dr. Michener for graciously agreeing to serve as Dr. Tan's mentor during the past several months as he has worked to wrap up his fellowship. Our third panel member is Dr. David Bishai, whom you heard from briefly at the start of today's program. Prior to assuming his current post as director of HKU's School of Public Health, Dr. Bishai served as a professor at the Johns Hopkins Bloomberg School of Public Health for 27 years, serving in the government as a health officer for the state of Maryland in 2021. As a world-renowned educator, researcher, and practitioner, Professor Bishai has made lasting contributions to scholarship. A leading health economist, his research focused on the performance and financing of global public health activities, primarily healthcare, vaccines, and health disparities. He is the author of 2 books and more than 260 peer-reviewed scientific publications, and his award-winning courses on systems thinking and health economics have reached more than 40,000 students. As president of the International Health Economics Association, he helped to establish a global mentoring network for early career researchers. I would now like to hand the microphone to our panel moderator, Dr. Park, to kick off a discussion by offering his thoughts on Dr. Tan's presentation, and then we'll hear from the other panelists, after which Dr. Tan will provide his reactions. As a reminder, for the final segment of our program, we will have time for questions from the audience, so please add your questions to the Q&A box on your screen so they can be read out by the moderator. Dr. Park, the floor is now yours.
Thank you, Dr. Margulis. So before I give some of my brief thoughts, just want to say it seems we're having some technical difficulty getting Professor Michener joining, but we will try and patch him through when he's able to. So I want to give some brief thoughts. It's first of all a great pleasure to hear my friend and colleague Dr. Nason Tan's presentation and to learn about a lot of these really insightful points of community engagement. I was particularly struck by the importance of radical listening. That's something that I tried to do during the presentation, but in fact, I think it really touches on a lot of work. And as some of my background has been in climate change, I thought that environmental climate aspect is very, very poignant, not just in the kind of local cases that were mentioned, but I'm thinking that, you know, in Brazil, this COP, the recent climate meeting has just ended, and thinking about, you know, the various roles of community engagement at that international level as well. Some of which seemed turbulent, some of which seemed maybe more successful. And so I kind of want to pry a little deeper and think about what Nason thinks and elaborate more on this call for courage and humility at the end, which I think is really perhaps in short supply at least a global level today. And so I wonder how we might connect that, you know, our individual work as teachers and academics to kind of global level challenges, because community is always local. How do we filter that up at a global level would be one of my takeaway questions, I would say. I might pass the floor to Professor Bishai so he can give his own reflections on this, on Dr. Tan's talk as well.
Thank you, Andrew. And I really do want to just celebrate what we've just been through with Nason's talk. It really is a refreshing perspective on this topic, and it's coming with a call to action, which I hope we can bring up in our panel discussion. I think we're approaching the call to action with the realization that we're not doing all we can, and we all seem to realize how important this part of public health practice is. Our cognate disciplines in nursing and medicine, dentistry, realize that you cannot be in the healthcare industry with one-to-one services unless you are engaged in humanizing and partnering with that one-to-one partnership. You have to hear an individual patient's story radically. You have to empower them to feel seen and heard and listened to if you want to be their doctor, nurse, or dentist. You can try to take a shortcut, and a lot of healthcare providers have to take a shortcut. They're embedded in a system that demands shortcutting, and patients respond by feeling dehumanized and failing to come for services because of that dehumanizing encounter in the one-to-one industry. But here we are in the one-to-many or the many-to-many in public health. We have to humanize whole communities. And this fundamental skill set that we want our workforce to have is what Nason's calling us to act on. The skill set of radical listening, of being a partner with a community, the whole community. How do we teach students and our current workforce how to be present and how to create the story of us, the story of our neighborhood, our housing district? What do we share in our exposure to health threats, and how can we all be part of the solution? That's what a community engaged practice would look like. And again, we're called on to take shortcuts. There's not enough time or resources, and the incentives aren't there. The incentives aren't there for our teachers, and our curricula have not fully embraced this. So the call to action that Nason's left us with is something that we really have to struggle with. And I'm hoping that these examples that Nason shared, where you bring students out to the community or you bring community into the classroom, some modification of that is part of what we'll do as better educators. We also could be researchers about that. To try to answer the question for a skeptical researcher, why? I'm busy doing an epidemiological study, and the only thing I really wish you'd do is get more participants in my study. So community engagement is a means to the end of getting me my research samples so that I can write a fabulous paper. Okay, but you're missing something if you are that type of researcher. You're missing that you are in a health practice, and public health is a profession, and it requires this type of humanization of the people that we're serving in order to be a successful profession. So I'm really thrilled that we are hearing and discussing these comments today.
Nason, would you like to maybe elaborate on some of those points, and particularly the call to action element, I think?
I think, as I mentioned before, on the critical shift, what is required so that we can actually move from what we are having now to something that's ideal, so that power sharing and also decision making, those are the three gaps that we need to address. And basically, the call to action is trying to address those three gaps as well. So whether we have the political will in our institutions or not, I think that's another issue that we need to think about. Back to your question on how community engagement done locally but applied globally, as you mentioned, and that is also the same thing as public health. Basically, there are things that we learn locally, but we could also apply globally. So it's the same skill set that we need in terms of like radical listening, that cultural humility, as in you should really learn, because we always struggle whenever we try to listen. We already know the solutions and things like that, and we just so dying to just tell them, no, 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 it should be this way. No, 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 what are you talking about? So I think that is something, if we are able to learn right at the start on radical listening or even active listening, and then bring that cultural humility, no matter where you practice or which community you go into, as long as you have that cultural humility, you would know then what sort of skill set or competency that you can use in that particular situation or setting. So I think, as I mentioned, the importance of having cultural humility, which is the key to sustainable community engagement. Yeah.
I might ask to pry a little bit more. So, what does cultural humility mean? Maybe I can get Nason and Professor Bishai to give some insights from your experiences. What, for a young student starting out in public health, what is the approach that you think they should take, and how does that look like? Maybe Professor Bishai, you can
Oh,
add
sure.
some comments too.
I think that there is a classic career arc for somebody who goes into training in a profession uh, where you start before your training wanting to be of help to the community, coming from the community, but then there's a bit of expert syndrome where you actually do learn and know things that you think ought to be done. And that creates the opposite of cultural humility. You become an expert and you have facts and you have science, and you say, this is really the fact-based approach that we should take. And I'm an expert and you should all listen to me. That is the opposite of humility. So I've defined the opposite. The humility would come from realizing that the expert can only be helpful if they realize that the community is an expert in something that you need too. They're an expert at their life. They're an expert at their strengths and their capabilities. And unless you recognize that all of your public health training and your degrees don't give you that expertise, then you realize that you need to be humble. And then you realize that you must partner, and to be your type of expertise in the solution finding has to couple with the community's expertise in its strengths and how to get things done. Then that is the sort of cultural humility coming out of a desire to actually succeed with the problem solving. But we have egos, and we're told that we're special, we're told that we're experts. And I've been in universities my whole life, and I'm sorry, but you'll hear this expert syndrome and you'll hear this um, condescension. It's there, and it is hurting us badly. This us them of the intellectuals, they don't get us, they don't care about us, they're in their ivory towers. That's real. And Nason, I think, might have a perspective on how to get around that, but it's very palpable these days.
Nathan, we can then follow up on that. So, how do we get around that? What are some more of your ideas and insights?
I think before that, maybe I can cite examples from experiences that I had in the past. So I was working with the one of the NGOs back home in Malaysia, dealing with people experiencing homelessness. So we see groups and groups of medical students who would come and just shadow us, and because we run the mobile clinics in addition to feeding program that we have, and over 1 week we actually have 3 nights that we go out on the streets and we do the mobile clinics as well as feeding the people experiencing with homelessness. So there was one incident where I shook the hands of the one of the patients or the people experiencing homelessness, and he cried in front of me. Do you know why? And he just said, "You are the first person, a doctor, who actually shook my hands. No one has shaken my hand for a long, long time," he said. "I could not remember when was the last time someone actually shook my hand." So I think this is where that cultural humility, as how we experience in real life in a different setting, could enlighten us. And this is how we get around this issue. I say you need to go into the community. You need to be with the people. You need to experience and see all this for you to know. So that's one example. The second example that I can share with you was that, so we also conduct haircuts for our people experiencing homelessness. And do you know why that is such a huge response every time? They will all come. Do you know what does it mean for them? So they will tell you, "Thank you for showing me how I used to look like, for showing me there is a better part of me that I've long forgotten, that you gave me back that dignity and pride." So these are the things that I think it's difficult to teach, but you need to experience yourself. You need to go into the community to experience all this. And that is one way of learning cultural humility. Now, I know a lot of universities, they have all these best practices, for community engagement and also doing community service, which is part of the curriculum. But the thing is, when you list down 10 best practices, as in be courteous or be respectful, but what exactly does it mean on the ground? How do you do that? I think that's the gap that we have in knowing and doing. So curriculum-wise, it's not enough to just giving all this knowledge, but we need to show how it is done. And I think that would be the key in teaching cultural humility.
Great, thank you for those examples. They're quite moving, actually. I do wonder, though, how do you think community engagement might look given today's headwinds? We don't need to mention them. They're probably quite well known, certainly in the US, but there's a lot of maybe headwinds against community engagement. How do you think this kind of the courage and humility needed looks in the face of political challenges that may be pushing in a different direction? Any thoughts, Nason?
Oh, I thought you might start with Professor Bishai.
Well, I can start with Professor Bishai as well. Or either of our panelists.
I think, Andrew, the unsaid word in your question is power, isn't it? It is power, and there's a long human history of the powerful being against community engagement because it threatens the power, the concentrated power of the elites. And this is why I think Nason may have referred to the work of Paulo Freire, which acknowledges the role of power in stopping this movement towards community engagement and community empowerment. I think our profession, as a profession, is allied, but should be, and I'm going to use the word should be squarely aware of the power dynamic. And as a profession, realize that we cannot achieve what our goals are in the health of the community if we defer to the elites to make all the decisions and to retain the power and to get in the way of communities that want to be part of solving their own problems. That creates a dependency. But my earlier answer realized how, as individual human beings, as professors and public health practitioners, power is important to us as well. And we might have to defer to the powerful to get research grants and funding for our schools. But we have to be aware that sometimes there's this hidden agenda that stops us from going out to the community to be part of the solutions that we want to achieve. That's the struggle that Nason's talk is about. There are headwinds, as you say, and we need to name them and see them because they're real. And every time we defer to the powerful to concentrate decision-making up at the very top, we're stopping ourselves from also, it's not always an either or. We can have both. We can have communities that gather together at the same time that we get the best insights and strengths of the powerful problem solvers. Over to you.
Any insights or more examples that speak to that question?
So when I was doing my attachment in Washington, D.C., climate change is highly polarized, right? The topic of climate change. So you have the right, you have the left, and even to mention the word climate change, that already triggers so many bells, so to speak. So then what sort of language can you use to replace climate change? Or how do you get people on board? So I would use back what Professor Bishai mentioned earlier, and that is the story of us. So make things relatable to everyone's daily lives. So instead of saying climate change, you can just say something as, oh, don't you find the weather is getting warmer these days? That could, be a way to start a conversation, and then you go deeper and find out more. So I think it's having that awareness of how to bring it all down to a more grounded level as how we actually connect back to the daily lives or daily activities that we can relate to and important to each and every one of us. So I think that would be the key to bring the right or left, to a topic that we can actually talk and discuss about. Thanks.
So, speaking of community engagement, I might open up the floor for any questions and answers as well. We do have one question from Keiji Fukuda, who is speaking about that very dynamic of power, particularly mentioning that there's this consolidation of power and wealth amongst the kind of super wealthy and powerful. How do we get around that? And basically, how do you make the argument for community engagement that goes beyond the logical academic argument? And KG poses the question, does it mean that perhaps it's only at the community level that community engagement is acceptable, that maybe it's not acceptable at a higher level?
Nason, your turn to start. I started it last time.
I need Andrew to repeat that question.
So I think the question in a nutshell is how do you basically make the case for community engagement? And I suppose which audience is appropriate for that? Should you maybe not even address a kind of power elite level for community engagement and just regardless of these power dynamics, just make the case for local communities, maybe sidestepping the high level power dynamics?
Right. Thank you very much, Professor KJ, for that wonderful question. I think if you really want to, and that is on the first gap, which is the gap of having sharing that power. So there's no way that you can just do one thing without having all the stakeholders involved. I would feel it's important that everyone has a seat on the table. All right. But then the next thing would be you might be sitting on the table, but you might not be participating, right? So you have that diversity in terms of stakeholders, but there's no inclusion. So in order for all the voices to be heard out there, to be put out there on the table, there needs to be inclusion in that regard. But before going in, I suppose it's also important for us to realize who are the major stakeholders, who wields the biggest power, so to speak, and what would be the engagement strategy be in terms of for this particular group, this is how I should approach, and this is the strategy we'll have. So is it using the collaboration strategy, or should I use the advocacy strategy when you see a conflict and you actually have an advocacy means of strategy? So I would say that you do need the presence of people belonging to the higher power group as well as the community to be involved in this discussion. One way of doing this could be having a separate discussion first, a small group discussion, and then later on, everyone could be on the same table. So that is another way. But I would think that the way or the approach should be everyone needs to be on the table for sure. Thanks.
Professor Bishai, any?
Yeah, thanks, Andrew. And thanks, KG, for this really thoughtful question. Yes, there are headwinds. Yes, what has happened is that powerful corporations, the ones that are leading the stock exchange right now, have monetized community, fake community, I would say false community. And we're scrolling our phones at night for this experience of finding meaning in a electronic social experience, which is a far weaker version of what we really were designed as human beings to reach out to. If you think about human evolution, tens of thousands of years of defining our personalities and our intersubjective identities out in groups of 50 to 100 members of our kin group. That's what our brains want. We're craving meaning and mattering to people that are in our community. And we've created organizations, this school is a community, this webinar is a community, but what the rich and powerful have done is monetize this crappy experience of likes and shares when we really want to be out in the streets and neighborhoods, of going out to see our neighbors and mattering to them the way generations of humans have done. So the non-logical is it feels better to matter to real people who you see in real life. COVID hurt our mental health because it took that away. No more COVID. Well, we're still stuck on our gadgets and devices looking at screens all day for a pale reflection of this type of community. The shared story of why would we gather with our community? Because it makes our neighborhood better. It helps our children thrive better. So there's a reason to have that conversation. So we crave the experience, and it creates the type of life that is meaningful because we need others to help create social meaning. So I think that is the response to how to sell it. But the best way to sell it is to go and do it. I'll take a little bit more time. Those of us who've traveled to the China mainland, out in the evening, if you go to any of the green country parks in a major city in China, you will see people getting this. They're out on the streets doing Tai Chi and square dancing, having community and creating better health. That is exactly an antidote to doom scrolling on your machine.
Great, thank you for those comments. We have another question that I think I will pose. This is from Zishuan Han, who is an interdisciplinary researcher in health geography and planning. And the question is really about whether there's an urgent and necessary need for interdisciplinary cooperation in related research and practices, and what are the specific disciplines and key points that you would recommend to focus on and participate in. We can maybe drop that to Nason again first. The interdisciplinary aspect is the thing. What other fields maybe need to be involved when it comes to community engagement, maybe in an academic setting as well?
I think medical anthropology, that is an important field as well, to understand the health-seeking behavior. That is important. So in a lot of the MSF projects worldwide, we actually employ or send out our medical anthropologists to the field to do surveys on health needs assessment, but also especially to understand the health-seeking behavior of that particular community. And that also involves community engagement, which is part of the intervention the same. So that will be one field I think that will actually be helpful in that regard. And I think I'm very happy to learn that Sichuan is actually an interdisciplinary researcher in health geography and planning. I think that's such a wonderful field. It's so important that community engagement is part of the discussion, when you do your research and how it can benefit the community. The other thing, just as I was talking to Professor Bishai yesterday and also Professor Sophia, is on the translation of that knowledge to practice. So after your findings, after your research, I think it's important to share those findings in simple layman terms back to the community that you were your participants. So that is also very important to share that knowledge to our participants or the community where this translation of knowledge to practice happens. Thanks.
Professor Bishai, any?
I'm going to give a micro case study. I know we don't have much time, but my small case study relates to Nason's problem of climate change and health. One aspect of that is heat waves in any major city on the planet. During a heat wave, there are many elderly who will have severe health problems. There's excess mortality. And the solution for it is interdisciplinary. A heat health action plan requires multiple parts of government and society. It creates a community engagement. It needs a community engagement platform. So our micro case studies here in Hong Kong, we've had a series of monthly heat breakfast where we embed our students so that they can learn how to be interdisciplinary practitioners of problem solving. So not just students, we gather members of the Center for Health Protection, members of housing, members from district council, members from the observatory, members from emergency services. They're all here in the common room on our sub-ground floor to work on creating and writing a local district heat health action plan. So the students see how to practice. We've gathered the volunteer spirit and effort of members of our community so that we're doing both collective problem solving, because a heat health action plan requires an early warning from the observatory, as well as some data processing of who is vulnerable and who can we reach them with. And then the NGOs have the ground troops that could go and reach out to those vulnerable elderly who don't have good ventilation or air conditioning. So it requires us to have the students see it. So we don't just give a lecture on it. You're in the room planning it, and we're writing our heat health action plan to deliver it to the Central and Western District Council. And then we're solving this problem down at the bottom of the district. Obviously, to scale it, we want to go to Legislative Council and the Chief Executive. But not all problems are first solved by the top down. So we're here at the bottom up, showing that multiple disciplines have to do it, and hopefully teaching by doing so that our students see it right here in our building.
So I think we have time for one last question, and we have a question from a first-year Global Health and Development student, Bob, who I think poses a really good question. The question is basically, we're bound to this kind of cycle of grants and success metrics based on publications and so on. How do we actually do radical listening when you're inside this structure that maybe is more rigid, that has various timelines and financial, limitations? And Bob's question particularly is, how can we practice slow relationship building with community actors in the face of this? And when we say intangible things like trust, empowerment, and social cohesion, can they be measured? So lots of big questions there for our last 4 or 5 minutes. Nason?
I think this is where the challenges lie, how we can bridge the gaps. As I mentioned earlier, that there are 3 critical gaps in this, and these are all the questions that Bob actually posed as well. So things have to change in terms of how do you write the grants, what things you want to measure. So unless the donors or the funders put that in writing in the fund perspective to say that, all right, we will now measure on your level of community engagement, the quality of it. And I've shown just now that's this conceptual model that NAM has proposed on how we measure meaningful engagement. So those there are indicators in there. It's too long actually, or too much for me to share in this presentation. But if you're interested, please visit the website on assessing meaningful community engagement. So they do have the key indicators on those things which are rather intangible, such as trust, empowerment, or social cohesion. So there are indicators available. You just have to go to the website to look at that conceptual model. And how we then change the institution or our funders on measuring things or giving grants longer than 3 years. I think that's the political will that needs to come in, either from the institution or from our public health institutions per se. Yeah, I'll pass it back to David.
Thanks for the question, Bob. I give an example of how you can outlive a short-term cycle. Thanks to my predecessor, Dr. Keiji Fukuda, our school decided to be accredited. And that process is a hopefully generational commitment to be accredited. And that requires our faculty to look at competencies and make sure that we teach them. And one of the competencies that we're committed to always teaching are these skills in community engagement. So now we've set up an accountability framework for our curriculum. We could do the same in practice. We could ask, just like hospitals have accountability for the quality of medical practice, departments of public health can also ask, are we accountable as health departments to be community engaged? And yes, you can accredit a health department. And if you did, you would have a multi-decade commitment to this practice of being present for the community in your organization. So these are tools, accreditation with measurement and motivation for the institution to deliver on those benchmarks is a tool that we could use, especially in this area of community engagement.
Great. Thank you, Professor Bishai and Dr. Nason Tan, for those insightful comments. I have one last question to put Nason on the spot. We've got 1 minute left. Very concisely, Nason, what is one thing you think all of us should do today in our everyday life right now that would help community engagement?
I think it's to constantly reflect on the existing hierarchies that we have, be in the institution, be in, academic or whatever, those in power, and what does it mean to you? And how do you see all this are being played in your daily lives, in our society? I think if we are constantly aware of all these things, if we're acutely aware, then things will start to change. Because once you have that mindset, then you see things differently. But if you go on in your daily lives without acknowledging this or even aware of the power imbalance in all these hierarchies and so on, then it's really difficult for us to even effect and change. So that would be my takeaway, based on today's session. Thank
Great.
you.
Thank you, Nason. Dr. Margolis, maybe over to you.
Well, thank you very much. And on behalf of all of the participants that are joining from around the world, please allow me to extend a deep appreciation to Dr. Tan, Dr. Park, and Dr. Bishai for a fascinating conversation on this very important topic. So thank you very much. I'd also like to note that Dr. Tan will be publishing a paper on his work in the coming months. And we will be sure to circulate a link to all of the attendees that are participating today once that paper has been accepted. We'll also look forward to the next of this annual series of webinars in late 2026, when our current NAM-HKU fellow, Juliana Jung, will be presenting on her work with us here at the National Academy of Medicine on the application of artificial intelligence in healthcare. This has been a joy to work with Nason, and thank you all to everybody that has supported his journey throughout the last couple of years, and in particular to Dr. Park and Dr. Bishai for your participation in tonight's session. I'd also like to give Dr. Zhao an opportunity to say a few words before we conclude this evening's event.
Thank you. The only thing I want to say is what a great event. I think Nathan, it's obvious you spend your time efficiently and effectively. And the things that you guys talk about are so important in engaging community. So thank you very much indeed.
Thank you, Dr. Zhao. And thank you all for joining us this evening, and to all of the presenters for joining. We hope that you have a great rest of your day and evening. And thank you again for your support.